All right, hello everyone, and welcome. Our first Innova chat, and we plan to have this every other week or perhaps every month, and bring industry leaders in post-acute care, long-term care, rehab, and healthcare technology. And really, the goal of the show is to inspire you and help post-acute care and post-acute rehab get ideas so that they can thrive in their business, and also look at technology in different ways, right? And look at technology and innovation so that we can continue to drive better care for patients. So today we have a very cool show, I think, or topic to discuss today because it's kind of hot off the press. And we're going to be talking about the 2026 Skilled Nursing Facility Prospective Payment System Proposed Rule that came out on April 11th. Obviously, this comes out every year, and the proposed rule will go into final rule in October. And I have two true experts to talk about the subject today and analyze the subject and get their opinions on what the impact is on this proposed rule for SNFs and particularly for rehab providers in SNFs. So we have Leigh Frick, who is president of Care Navigation Consulting. She's been in the industry for quite a few years. Also acted as president or chief clinical officer, sorry, for Health Pro Heritage in past life, but now she's running healthcare navigation consulting. And we also have Mark Hyder on the show today. He is the chief operating officer here at Innova Health, and he will be also diving into this topic. Mark also has quite a few years of industry experience as a chief operating officer for companies like Brightview, for example, and other SNFs and therapy companies. So both of them are very well versed in this topic. So I can't wait to dig in. My name, by the way, is Luis Montes. I am the founder and CEO here at Innova Health. So without further ado, let's jump right in. So I want to keep this short and
Exciting. Let's
sweet.
get going.
We're gonna get
Yeah,
this short.
right.
We're gonna keep this short and sweet.
Yeah.
So let's do this. So I'll start with just kind of like to bring us, to kind of like level set here. If Leanne, if you can just walk us through the top 3 to 5 proposed changes that we see coming, or that you see coming, right, on this proposed rule in your opinion, and then we can start digging deeper.
The top. Well, obviously everybody starts with
Your opinion.
my opinion. I think we always have to look at the dollars, right? So there was a proposed 2.8% increase, not quite as high as last year, certainly not quite as high as the MA, but at least it's a positive, so we're happy about that. Some changes in and around the value-based purchasing and quality reporting. And then, of course, we always have to be cognizant of the ICD-10 mapping.
Mark, any additions to that? Obviously, we
The,
want to
the
start
one,
dissecting those, but any additions to you that kind of jump out?
absolutely. The one that's not part of the proposed rule, but is going to affect us are the RAI changes, the MDS changes. I think they're very important to look at. But I think Leanne hit the nail on the head. People look at the money first, which is important. And it looks like a big dollar amount, but if you look at the percentage versus what's going on in our economy, and you're looking at inflation, it's a pretty small adjustment. And we're really going to have to be conscientious as an industry and make sure that we know that this may not cover the increase of costs for the next year.
Yeah, good point. Well, let's start digging in there, right? So, in terms of the ICD, there were some changes to ICD-10, right? So, um, can you tell us how will this affect reimbursement, these changes in ICD-10, and where, what are some of these changes? I know that some of them are related to ICD-10s relating to nutrition, right? Or the diseases related uh, to nutritional type of dysfunctions. So how will that affect reimbursement rates? Mark or Leanne.
Well, one of the first things that's really important for people to understand, and most people know it, but a lot of people don't, is that ICD-10 code changes happen every single year. There are a number of codes that are pulled over, and what happens is people come up with their cheat sheets. It's a hard copy. They keep it on their clipboard for those people that still have clipboards, or it's taped next to their desk. And they need to make sure that none of these codes are on that. Like I said, a lot of them are nutritional type codes, but they've changed some codes from being in the medical management to being return to provider, meaning they can't be a primary diagnosis. So on the MDS, if they're put on a primary diagnosis, they're not going to trigger payment.
Yeah, so some of those codes include diabetes, hypoglycemia. There's some eating disorder codes, obesity, things of that nature that Mark referenced. They did add a serotonin syndrome into medical management, but I go back to exactly what Mark said in and around knowing, accessing the ICD-10 mapping file, which is an Excel file, and it gives you everything you need to know in and around PDPM by tab, by component. And so, making sure you have access to that and have some awareness of what those codes are and the changes for sure.
And I would add to that, making sure that the EHR that you're using is up to date with those current changes, right? Because if you're coding something that's returned to provider, yeah, you're SOL, right?
Right. Yeah, it's going to kick out. And remember
Right.
the whole basis of ICD-10 is in and around specificity, right? And accuracy. So
That's right.
making sure we're using as specific a code as possible.
Yeah, excellent. So let's move on to QRP, right? I think that there's some important elements here. And one of them that I'm curious about to get your opinion on it is why is CMS proposing to remove some items that were previously adopted under the social determinants of health, right? Like, what is the rationale behind taking out some elements like living situation, utilities, food, and such? Like, what's going on there?
I like her big smile. I think, and I love their explanation. There is a huge administrative burden with the MDS. For those people who are familiar with the MDS, it's grown and grown and grown and grown and grown over the last 30 years to where it's almost 60 pages. And that's a lot of information to gather. And with CMS looking at having different technologies interface and exchange information, there should be a more efficient way for us to get this information. So I'm really hoping it is what they say and reducing the administrative burden. Sometimes it doesn't feel like the administrative burden's being reduced at all, but I'll go with that. What do you think, Leanne?
I love your rose-colored glasses, Mark. No.
All I got.
I mean, right, exactly. I don't know. Does it really matter? At the end of the day, most likely those things are going to go away from the MDS because they feel like, as Mark said, there should be a digital transfer of information, some sort of interoperability that gives us that. I would argue there's a lot of other things that should be in that sort of an interface as well. But at the end of the day, what I would caution everybody is that while it most likely will go away from the MDS, that information is still critical and vital to discharge planning. And if you're paying attention to the updates of the Appendix PP and survey and things of that nature, we need to know that stuff and we need to incorporate it into our care planning and our discharge planning. So whether or not we have to answer those 4 questions, but at the end of the day, we're still going to need to gather that information, I feel.
For sure.
Yeah, and I kind of chuckle a little bit because I think I know where you're coming from, Leanne. I was reading part of the proposed rule for that, and they actually did the math on the admin burden, right? Like the time it actually takes to enter this, right, and to document this, right? And it turns out to be like millions of dollars, right? Like just a few millions of dollars, which is like it's really talking about like a really insignificant amount of cost savings, right, to the system. But hey, it's they're proposing it, right? So that's what we're talking about, right?
That's right.
So what what I think is a big deal, right, in this proposed rule, and really not just in this proposed rule, but really where the industry is heading, right, is value-based payment, right? And there was a lot of comment around and proposals around, value-based payment, right? So for those of us that perhaps are not that familiar, that are watching this, in terms of, can you just describe in a nutshell, what the aim is for value-based payment in a SNF setting, right? Since we're talking about proposed rule in a SNF, right? And tell us, a little bit about, how you see this playing out, not just on the proposed rule, but how value-based payments will be playing out over the next, 5 years, 10 years. I want to hear
Sure.
from both of you guys because this is a big deal, right? So,
Right. Well, I'll start in this one and then Mark can chime in. But,
yeah.
I think it's important to realize value-based purchasing program is an earn back, right? So they take 2% and then they give you an opportunity to earn some of it back, not all of it, right? About
That's right.
60-ish percent.
Mhm.
And so from that perspective, again, inferred in there is they're trying to ensure that we are demonstrating value and that we are accommodating the patient's needs in such a way that demonstrates that value. So for years, we've had one measure, and it's been in and around rehospitalization. And coming into 2026, we have some additional measures in and around nurse staffing, infection, healthcare acquired or associated infections, as well as the nurse staffing and nurse turnover. And I
Right.
think that, from that perspective, from a therapy perspective, not really, affects us directly, but we're on the docket, right, coming into the next few years. And we're in the data that we are collecting in and around Section GG is going to play into the discharge function measure. But from a broad perspective, those are kind of the high points of kind of what it is and what it's doing. What I missed, Mark?
Mark,
No, I
anything
think
you
you did
want
a
to add
very good job. It's concerning though, the behind the scenes. So we've had the rehospitalization measure for a long time, and then we see other measures being added to both the value-based purchase and the QRP. And at any moment, the government could start pulling those triggers and saying, now we're going to base repayment of that 2% based on a multitude of items, some of which cross over from both both of those programs plus the 5-star. And so you're looking at potential either reward or penalty based on how you're doing on those programs and those items. Rehospitalization is a huge one, and it should be. And one of the things we've seen is the government has focused on items like rehospitalization. The industry's generally improved, generally.
Yeah.
And with the QRP, it was based on completing the MDS at first. That was really the trigger. Get it done and stop dashing the fields. And we stopped dashing fields
Yeah.
because there was a penalty, and now they're raising the benchmark on that, and they're adding other measures that we're taking those measures, we're providing those measures to the government and to CMS, and at some point, those measures are likely going to guide payment. It would be nice if they'd merge those two programs because they're starting to mirror each other in a lot of ways between the discharge function score and the falls with major injury and some of those other things. But until they do that, there's growing risk if you're not really good at those measures.
But growing reward if you are.
Absolutely.
Right.
Absolutely.
But yeah, you're right. You're kind of getting, double dinged or double incentivized, right? Either way you look at it. And that could be good or that could be bad. But I
Yeah.
agree. And what's the point of having the same things across all? I mean, I think again, go back to burden. The repetition, how, does that make any sense?
Yeah.
One of the things related to the value-based purchasing that they are proposing to take away, they had proposed a health equity adjustment in and around the
that?
dual eligibles, right? And they're
Right.
proposing to take that away because that would have complicated the calculation. And so again,
Right.
from a simplification perspective, that's the, the reasoning for the proposal to remove that health equity adjustment.
Yeah, and I think when you talk
Yeah.
about pay for performance, the one thing that sticks out to me is that new discharge function score. I guess it's not new anymore, the discharge function score. And as much as we want to talk about all these other programs, this is the one piece that they're tacking it on to everything. And for years, therapy companies have tried to come up with their own ways of measuring success and outcomes. And I think this is CMS's way of saying, this is the measure that we're going to use that will show us the effectiveness of the intervention, whether it's nursing or therapy. This is the calculation. So all these other things we've invented, kind of go out the window. And we've got to focus on that one piece if we want to really play in this game.
I'd just put them on the ledge, though. I wouldn't throw them completely off. Just put them on the ledge, Mark, because you never know.
That is true.
So the takeaway is to just never do a time up and go test ever again, because you just don't need to. Or a Tineti, right?
Yeah,
or
right. If it were that simple.
No, this is not the takeaway, guys. That is not the takeaway.
No, not the takeaway.
Yeah.
But you make a good point there, Mark, right? With value-based payment, one of the things that I want to, get your feedback on, right, is the discharge score is essential, right, in therapy, right? Because we have mobility and self-care, and obviously all of that is, it's on the MDS intersection GG, right, which becomes a center stage of what we were trying to measure, right? But we also see on the value-based payment falls, like fall prevention, right? Readmissions, right? We have a new measure, right? Which is, what's it called?
Within state potentially preventable readmission.
Yes, within state potential, preventable readmission, yes, which is replacing the other readmission, right? So maybe talk to me about that, right? In your opinion, right? Like, what is the role of therapy here, right? I see three things that directly impact, right? What we do in rehab, right? In physical therapy, occupational therapy, speech, right? Those three things, right? The discharge score, the falls, and readmissions, right? Is that what we ultimately should be judged on?
What do you think, Leigh? I'll let you go first.
Yeah, thank you, Mark. Right. Well, so, it comes down to what is the value of therapy? What are we trying to accomplish when we interact with folks? And so we have to show, right, that what we're doing is working, or at least that's our intent, right? And so from that perspective, when you're talking about the discharge function score, it's very imperative that we get accurate information in section GG upon admission. And when I say accurate, I mean follow the RAI manual instructions, and it should be an interdisciplinary collaborative approach based on all the things, the clinical assessments, the patient's reporting, the family, so on and so forth, right? Therapy should not just be putting their numbers in that. And so accuracy upon admission and discharge are critical. And understanding that that function score is, what did we accomplish from beginning to end? Right? How long did that take us? What did it cost Medicare to do? And how does that compare to others? Right? And how does it compare to what CMS's calculation of an expected discharge function measure should have been? Right? So if you trigger for that, that's a good thing. That means you met or exceeded the expected discharge function score. Right. And I can tell you in preliminary reports I'm seeing, we're at about a 50-50. In a lot of scenarios. So, what we do, how we do it, and how effective we are is going to mitigate falls, should mitigate rehospitalizations, and should demonstrate an appropriate discharge function measure, hopefully triggering that. What do you got?
I love what you're saying, Leanne, because one of the things I've seen for the last couple of years, and I've actually seen it over time, but it's now affecting this score, is our baseline scores for section GG and that discharge function score. They're artificially inflated when we use therapy as the sole provider. And a lot of companies, a lot of nursing homes and providers are still feeding the therapy scores right into it because it's easy. It's easiest. But when you look at usual performance, they're usually performing most of these things many more times outside of therapy than they are in therapy. And therapists, they're trained to get the best performance. So
Ah,
at first, besides getting the best performance, once you've initiated your intervention, then the score should no longer count because you've already initiated your care, your treatment. So you're now using tainted information. So it really concerns me that we have an artificially high benchmark, and so we're never going to show the amount of change that we really want to. It should be here, and yet it's probably right here. And so the difference in change is very concerning. The other thing, and I've heard this for years, we're at a crossroads. Our industry's at a crossroads. We really are. When we look at what is being asked, we're being asked to show a change in this new scale. We're also being asked to show that there's some durability of our outcomes with rehospitalization. We're being asked to show that what we're doing is preventative with some of these falls measures and things like that. So the more we get into that mindset of let's really look at what do we add that we can measure for preventative that really prevents, emergency room visits that we're now looking at and stuff like that. That's where I think therapy needs to move is really look at that preventative and what do we do for the entire facility and how do we accurately show the starting point and the ending point.
Yeah,
that is really interesting. Go ahead, Leanne.
I was just going to say, and there's some evidence that they're interested in kind of wellness and well-being and prevention and some of those things. I know
Yes.
the new administration appears to have some of that on their radar. And I mean, we've all been somewhat wanting that for years, right? Why we don't want to wait till something happens to be able to get involved in a patient's care. So I'm kind of excited about that, but this time we're really serious about the crossroads, right, Mark?
Absolutely. This is a crossroads. It's not a virtual crossroads. So, the thing I always get nervous when we allow the government to set a course for us because we haven't set our own. So it would really be nice if we could come together as an industry and really figure out what skilled therapy looks like. And in addition to that, what skills can therapists use in the facility that aren't necessarily counted as skilled, but will work towards the preventative and work towards the wellness of the facility and the betterment. It really will reduce dollars spent if we can stop rehospitalization, we can stop falls, we can stop, pressure ulcers, those type of things that don't pay well on the front end. They've always paid well on the back end, but that's being taken away as an option. So we need to figure that out.
So we should make minutes matter.
Okay.
Absolutely.
All right. Well, you want to go there now? Let's go. Let's go. Minutes. We'll go to minutes. We'll go there. But before we go to the minutes, right? Conversation. So this does remind me a lot of the iSNP model, right? And there's a lot of SNFs out there that are embracing this iSNP model, right? And for those of you who don't know, what iSNPs are, maybe we could talk a little bit about that because I think there's a theme here, right, with that type of model, and that type of model seems to be working, right? So maybe Leanne or Mark, you can tell us a little bit about that as well.
Yeah, I'll start. iSNP, Institutional Special Needs Plan, right? And these are folks that live in our facilities and have Medicare Part A, Medicare Part B, and it's a value-based plan, a managed essentially managed care type plan where the plan gets a per member per month amount of money to take care of all of their needs. It's all inclusive, right? Kind of like PACE, but it's institutional based. And so from a therapy perspective, again, fee for service, the more I do, the more I bill. the more I hope I get paid kind of thing. And it's just not a system that's set up to be efficient or, really cognizant of kind of what we're doing and how we're doing it. And I think a special needs plan allows us that flexibility to use our clinicians a little bit differently, to use some extenders a little bit differently, and really focus on that, top of license approach. But therapists are still doing that in a sort of fee for service scenario or setup contractually, but some of them are really taking it to the next level and doing a similar per member per month, just like the program does. And then they have to manage the care for all the residents in that ISNP. And I'm excited about that. I think that gives just us a better opportunity to show our value as well as be innovative.
Absolutely. The thing I'd add to that, the caution is there's a potential downside. I've seen it work and work really well, and I really like the ISNP program. The downside is that financial component when finances are really driving decisions, because there is a capitated pool. You have a pool of money, and every service that you provide generally comes out of that pool. And so some of the decisions that are being made are a little concerning, but that's where therapists have to show their value. That's where they really have to say, I believe I can help this person, and here's where I think we can go, and here's what it's going to take. And to Leanne's point, there are a lot of services that we've provided over the years that CMS is questioned as being skilled, requiring the skills of a therapist. Exercise bikes, new steps, stuff like that. These are those times where you really can and should be using extenders, using RNA, using exercise aids, whatever you want to call them, to augment what you're doing to really focus on outcome. And what Leanne said, working at the top of your license.
Yeah.
Here's what takes my skills. Here's what you can do. And here's how I'm going to help you manage this so I can help manage the outcome and really produce a great outcome.
Yeah, I would agree with that. I mean, I think that there's going to be in a value-based payment model, where there's value-based payment as driven by the government, like with this proposed rule or ISNPs or anything like this, we're going to start to question the real skill of the licensed therapist, right? Specifically, PT, OT, and speech, right? Because if we can drive a wellness program with an athletic trainer and I pay him a fraction of the cost and I do a PT, right? Why would I have a PT involved in that wellness program, right? Or if we have a restorative program, right, that's being driven by nursing team, right? So I think that therapists are going to start, facilities are going to start looking at therapy at those higher skill level, type of patients that really, really need the skill of the therapist. So I think that facilities are going to start really looking at the real skill of what the therapist has to offer, right? I might be playing a little bit devil's advocate here, right? But I think that's going to decrease, right, the utilization of therapy in my point of view. But I think that there's other opportunities for therapists to also get involved in leadership roles of managing all of that, right, for a facility. And perhaps maybe you can, I don't know if you guys have seen that happening, where a therapist is actually orchestrating, right, a wellness program, but they're managing, right, maybe athletic trainers, or they're managing other disciplines.
I've actually seen that, and it's emerging, and I think it's a great direction for therapy to go. In fact, our brighter post-acute care leaders are really looking at outcome. What does it take to get the right outcome? And they're using the right players, because therapy is no longer a revenue center, could be viewed as a cost center, or it could be viewed as that outcome catalyst. And that's what we want to see, is the outcome catalyst, not necessarily a cost center. But in order to do that, we really have to have buy-in, and you have to have programs. You have to plan these things. And that's part of the problem as we've got into like a big productivity model. Somebody has to be really designing programs to get the best outcomes, and really retraining therapists to think in outcomes rather than productivity. And I know that'll rub people wrong, because I'm not saying that people shouldn't be productive. What I'm saying is they should be productive doing the right things, And the post-acute care leaders need to be looking at how they're getting their outcomes and what that outcome equates to. You have to look at it as a whole rather than just the one department.
Well, and I would just add to that, Luis, you mentioned maybe less therapy involvement. It's certainly going to be a different level of therapy involvement, and I don't know necessarily if I would agree 100% less, but because if we have the ability to be more proactive, right, it may just be we're getting folks, at different times versus, again, waiting for something bad to happen and then trying to rehabilitate them. So it may be shorter stints or little kind of, interventions that then we quickly pass over to one of those extenders, exercise, physio, whoever. But we're, still managing, as Mark mentioned, that kind of capitated rate, or being a part of the management of that, so that we get the outcomes that we need.
Yeah. And the risk is less unless we show outcomes and we show value, because we're not being directly reimbursed for a lot of our services like we were. So the risk is there. I agree with you. It shouldn't be. I think we should drive better outcomes.
Well, what's interesting is that, with this kind of push towards more of a holistic approach to the care of the patient, right? Which the goal is to drive a better outcome. We're getting towards the end of our conversation here, but I want to talk a little bit about request for information topics, right, on this proposed rule, because CMS is requesting information, right, from the industry, and one of the things that they're requesting information for is on well-being, right, and nutrition, right, and then we'll get a little bit more into the health data exchange and interoperability request for information there. But since we're on this topic, right, why are they requiring information on well-being and nutrition? I think it's more of a rhetoric question, but I'll like to get your angle on that.
Go ahead, Mr. Hyder. I'll let you start on that one.
One of the things that I look at when I look at well-being, and we've had 4 years of governmental oversight that was less than friendly towards the long-term care sector. And I think as a sector, an industry, not just therapy, but as an industry, we really have to show that we are taking very good care of our residents. And that means holistically, that they're getting nutritious food that they enjoy eating, that they'll eat, that they enjoy the environment, that they feel cared for, that they're giving positive feedback. Otherwise, you're going to continue to see a stronger push towards community-based services. I support community-based services, but I also see a segment of our population that potentially wouldn't be served well in the community, and I think that's what we need to protect. Give them the information to show that our service is valuable as an entity.
Yeah, I mean, I don't disagree, Mark. I mean, I think it makes sense, because I think when people are in the right space, the right headspace, they're engaged, they feel better, and they get good nutrition, that just compounds outcomes, that compounds the ability to impact them positively and things. I mean, I know every one of us on this call, value the ability to go for a hike, go for a run, there's things that we do for self-care. And so, I'm happy to have that holistic approach, and to make sure that, we're also engaging the patients at that level. And when you think about the triple aim, the quadruple aim, the quintuple aim, and looking at, all the aims, and we're looking at healthcare workers, mental health, we're looking at now the patient's mental and physical health as it relates to those sort of things versus just the medical model. So I'm excited about that.
Yeah. Well, I'll tell you what, I always have a better workout when I eat better and I sleep well, right? So
100%.
Switching topics a little bit, from value-based payments and wellness type of programs and initiatives. Another topic for request for information was on the data exchange and interoperability side of things, right? Which I find really, really interesting. Obviously, with Innova Health, we're doing a lot of things around that. But what are some of the things that CMS is looking at, or what are they requesting for information in terms of interoperability and standards and things of that nature. Mark, maybe I'll start with you and then, Leanne.
Oh, I was going to let Leanne start with this one, but I'll take it. One of the things that's frustrating for healthcare providers and for the patients and their families is they'll tell their story 20 times. And by the time they change settings, they go from the hospital to a skilled nursing facility, they're exhausted. They wonder why their medications don't flow over. They wonder why their history doesn't flow over. They wonder why they have to tell the same story. It's exhausting. And so just by having a record that flows over from site to site makes so much sense. You're not chasing information. You're not seeing as many discrepancies. You really are able to get to the care part. And I think from what I'm reading, that's where the current administration is looking, is get to the care. In fact, when they're talking about alleviating some of the administrative burden, that was their focus, is so that we can get to the care. So if you don't have to ask the same questions, you don't have to type in the same information, you're getting rid of some of those fat finger errors, you're getting rid of some of the other errors that happen when you transition. It should make for a better patient experience. And we know better patient experiences really result in better outcomes. And that's what we really need.
100%, 100%. I think the challenge that we have, and we know this, is that, when they, and I forget, was it MACRA that they did the interoperability of, and incentivize hospitals and physicians, right, to go electronic and do all the things. And the SNF world didn't get any of that. We didn't get any money or support or resources for that, right? So, they're asking questions in and around, what are you exchanging? How are you exchanging it? How are you sending your MDSs? Are you, using a third party? Those kind of, they're asking a lot of questions, and that's great. When I think about the interoperability, and I've learned a lot about this, I'm just a PT, but I've done some things in and around the PASIO project and post-acute care interoperability. You can't exchange data if it's not in the same format, if it's not, if that's not compatible, if you will. I'll use simple terms because I'm a simple PT. And so I think it's great, but in my head, asking these questions and gathering this information, we are still a far way away from actually executing on it. And to me, that would eliminate a lot of waste if we could get there quicker. Because as Mark said, just send us the information so everybody has it, and the poor patient and family doesn't have to say it 6-7 times.
Yeah,
Absolutely
right. And we know a lot of entities that we see and talk to that are still using outdated systems. They're not even to the current standards. So, grandfathering or sunsetting some of those, not a bad idea, but there's a cost. And until the government is willing to help offset that cost, it's going to be difficult to move forward that way.
Yeah, definitely. Leanne, you mentioned meaningful use, right, back in 2008, 2009, right, and where the acute care space and physicians, right, were incentivized, right, to adopt electronic health records, right, and that actually worked, right, because the entire acute ecosystem and physician practices, they were incentivized, and those incentives work, and they switched from paper to electronic, right. It didn't happen in post-acute, so it took a lot longer, but we're there. I don't see any SNF providers right now, or home health agencies or IRFs or LTACs, doing paper charts. There must still be a few, but very, very few. You're talking about like less than 2%, right? I think that the new paradigm now is like, how do we exchange data, right? Like, how do we exchange that information? And I think that CMS is really looking at certain standards, right? Like FHIR, for example, being one of them, right? To get embraced across, all EHR systems, and even get the ONC involved to certify electronic healthcare records, right? Looking at how well they can exchange, data, right? So I think that's an interesting initiative. And I think what's really more interesting is that, CMS is looking at making interoperability a QRP measure, right? You
Right.
know, and they're looking at kind of like what MIPS did, right? Back, like for outpatient therapy and for physician groups, right? The merit incentive payment system, right? And I think that's interesting, right?
Yeah, and again, I think that their intent is all positive in the sense of trying to make things faster, to streamline, to have some consistency, and to your point, standards, to exchange the data. And yes, everybody is pretty much electronic, but there's still costs in the exchange and setting up, because the acute systems are very different than the post-acute systems, to the therapy systems, to the wound care systems, to the, we get all these bolt-on products, if you will. So, but yeah, I'm happy to see that they too, there's a technical expert panel. I know they were gathering together in and around that. So, they're headed in the right direction for sure.
All right, so this is a big topic. Obviously, a lot in this proposed rule. A lot more to come to in October as we go into the final rule. So we might do a follow up on this, right? And just see how much of this proposed rule actually made it to the final rule. But final takeaways, right? In your opinion, Leigh and Mark, what are the things that SNFs and rehab programs should start doing now to get ready for these changes?
I'm going to go with, oh, sorry, Mark. You want to go first?
Oh, go ahead.
Again, I think what we do and how we do it is we just need to be focused on providing quality, effective, evidence-based care to our patients, right? And within whatever constraints we have as it relates to payers and this and that and the other, and practicing at the top of our license, being educated in ICD-10 coding and understanding, the impact of that. But at the end of the day, what we're trying to do is treat the patient effectively, holistically, prepare them for that next level of care.
Love it. Mark, can you top that? I'm not sure, man.
I agree 100%.
That's beautifully said, I must say. Yeah.
It is. I literally would dive into that discharge function score because it covers so much area. The QRP, value-based purchase, 5-star, that is your public facing information telling people how you perform as a facility. And Leanne's 100% right. It should be holistic care, but this is one of those items you should not ignore. You should make this a focus of training, get those baseline scores where they should be. Stop relying on the therapist to collect all that because that's the wrong model. You really want that from your aides, your family, your nurses, and then compare it against your therapy, what you're seeing, and make sure that you're giving an accurate view because it's going to impact public perception and payment. And it doesn't get more serious than that.
Love it. All right. Well, I think that's an appropriate ending to our very, very first show at Innova Chats, if we decide to call it that. And this is history in the making. We had amazing guests on this first one, and we have a tough act to follow now because now we got to keep the standards up high, with this first one. So thank you guys for all your feedback and knowledge on this proposed rule. I hope that this helps out. All of those that have watched this episode, I hope that you get some ideas. I hope that you get inspired and go back, to your practices, go back to your facilities, and get some of this knowledge, this information that we shared today, and make great things happen. So, thank you guys. Have a wonderful day.
Thank you.
Thank you.
And till later.